Welcome, stress nursing students. Look, if you are feeling the pressure of NUR 2356 right now, just take a deep breath. You're in the right place. This explainer is your ultimate high-yield toolkit designed specifically to help you absolutely crush Exam 2. We're taking the exact concepts directly from your roadmap, stripping away all the extra fluff, and zeroing in on the absolute must-knows. We're talking hearing, balance, and those absolutely crucial do-not-miss red flag emergencies.
Okay, here's our roadmap for today. We've got 6 key areas: assessment and hearing tests, drops, irrigation and communication, hearing loss and injuries, ear infections uncovered, vertigo and balance disorders, and we'll wrap it all up with NCLEX priority red flags. Let's get to it.
Starting right off with Section 1, Assessment and Hearing Tests, the foundations of ear care.
So any assessment starts with a basic visual inspection and palpation, right? We're just looking for obvious lesions, discharge, or tenderness. But here is the critical procedural step you will absolutely be tested on. When you are dealing with an adult patient, you must pull the ear, the auricle, up and back. Whether you're about to insert an otoscope to look for that nice, normal, pearly gray tympanic membrane, or you're giving eardrops, pulling up and back physically straightens out that ear canal. If you remember literally nothing else about eardrops for adults today, remember up and back. Now, you might be wondering about those tuning fork tests. It is so incredibly easy to get the Weber and Rene tests mixed up, so let's lock them in. For the Weber test, imagine the tuning fork going right smack on top of the head. A normal result there, the sound is heard equally in both ears. Simple. The Rene test, on the other hand, is all about comparing air conduction to bone conduction. And here is a fantastic memory trick from your materials to ensure you never, ever forget the normal Rene test results. Just think, Rin equals the right order, which means air over bone. I'll say it again, air over bone. Air conduction should always be greater than or heard longer than bone conduction. Keep that in your back pocket for test day.
Moving right along to Section 2, drops, irrigation, and communication. These are your everyday nursing actions on the floor. You know, communication is a massive priority on your exam roadmap. When you're speaking with a hard of hearing patient, you need to face them directly, make sure the lighting is good so they can read your lips or see your facial expressions, cut down that background noise, and speak clearly and slowly. And here's the kicker. Louder does not mean clearer, especially when dealing with high-frequency hearing loss. You should never, ever shout at your patient. Just don't do it. We also really need to touch on a vital cultural nuance here. Notice the difference between the uppercase deaf and the lowercase deafness. The uppercase deaf refers to the incredibly rich culture and community connected to sign language and self-determination. Actually, scratch using the term hearing impaired altogether. It's widely discouraged because many in the community consider it demeaning. As a nurse, you always base your communication method on what the patient prefers. Maybe that's writing, maybe it's lip reading, or using an interpreter. Never just bypass the patient to talk to their family.
Okay, let's talk about ear irrigation for when a patient has a nasty earwax or cerumen impaction. I want to shift our focus entirely to safety for a second. Step 1, never use cold water. Seriously, unless you want your patient to literally start vomiting all over you, use warm water only. Step 2, apply gentle pressure. If you go in there blasting forceful water, you can blow a hole right through the eardrum. No way we want that. And step 3, the second your patient reports pain or dizziness, you stop immediately.
All right, Section 3, Hearing Loss and Injuries. What happens when things actually go wrong?
So there are 2 main buckets of hearing loss. Conductive hearing loss is essentially a physical roadblock in the external or middle ear. Think earwax, a bad infection, or a foreign body stuck in there. The good news? It's often totally reversible once you clear that blockage. Sensory neural hearing loss, though, is a whole different ballgame. This is nerve damage. We're talking damage to the cochlea or cranial nerve 8, caused by things like aging, chronic loud noises, or toxic medications. Because it's a neurological issue, it's almost always permanent. Look, we all know the pressure of nursing school can literally make you feel like your head is about to explode. But what actually happens to your patient when physical pressure, like from a severe middle ear infection or a blast injury, builds up way too much in that tiny ear space? Well, the eardrum finally gives way. That is a tympanic membrane perforation. Patients will often report this severe, intense pain that suddenly, miraculously feels better the exact moment it ruptures. That's usually followed by drainage and hearing loss. Your big nursing teaching moment here? Keep water completely out of that ear. Oh, and a huge red flag. If you see clear, watery drainage coming from the ear after a head injury, do not assume it's just ear fluid. That could be a cerebral spinal fluid leak masking itself as ear drainage. You report that immediately.
Section 4, Ear Infections Uncovered. Let's compare externa versus media.
It's super important to know the difference here. Otitis externa, which most people just call swimmer's ear, is an infection of the outside canal. The key giveaway? Pulling or moving the outer ear really hurts. Then you have acute otitis media. This guy is deep inside, behind the eardrum. It almost always follows a respiratory infection, comes with a fever, and moving the outer ear won't necessarily bother the patient at all. But if you look inside, that tympanic membrane is red, angry, and bulging. Moving on to Section 5, Vertigo and Balance Disorders. Welcome to the spinning world.
You absolutely have to know this classic triad for Meniere's disease. If you have a patient presenting with episodic vertigo, tinnitus, you know that annoying ringing in the ears, and fluctuating sensorineural hearing loss all at the same time, boom, you are looking at Meniere's. It's caused by this crazy endolink fluid imbalance deep in the inner ear. And the critical nursing intervention you're going to be tested on? A strict low-sodium diet to help manage and prevent that fluid buildup. Let's do a really quick rapid-fire comparison of 3 other balance disorders. BPVV is sudden vertigo triggered just by changing head positions, but note this, there's 0 hearing loss involved. We treat it by physically repositioning little calcium crystals in the ear. Wild, right? Labyrinthitis is this sudden, severe inflammation that often brings on horrible nausea, vomiting, and hearing loss. But look closely at acoustic neuroma. This is a slow-growing tumor on cranial nerve 8. The massive red flag word here is unilateral. Unilateral tinnitus and hearing loss means you need a sharp eye, and if they go into surgery, you must monitor that facial nerve afterward.
All right, listen up, because here is the absolute golden rule for your exam. The priority problem for all vertigo patients is fall risk. On any nursing exam, physical safety always wins. Teach your patients to keep their heads still, to literally sit down the second they feel dizzy, and you as the nurse need to make sure their environment is completely hazard-free.
And finally, Section 6, NCLEX priority red flags. These are your rapid-fire exam must-knows. First up, ototoxic medications. These are drugs that can literally poison the ear. If your patient is on aminoglycosides like gentamicin, loop diuretics like furosemide, heavy doses of aspirin or cisplatin, as the nurse, you must monitor them for hearing changes and tinnitus. And here's the connection to make. Because these drugs are often really tough on the kidneys as well, you've got to keep a super close eye on their renal function.
Now, catching a quick pivot straight from your roadmap, do not let the eye disorders catch you off guard. The source material makes this crystal clear. There are 2 major eye emergencies you need to spot. If you see retinal detachment or acute angle closure glaucoma on your test, you do not wait. You do not just monitor. These are immediate, sight-threatening medical emergencies. Call the provider.
And one final massive safety alert to permanently lock into your brain. You never irrigate an ear if the tympanic membrane is perforated. You do not ever push fluid into a middle ear that has lost its protective barrier. Doing that is basically inviting a severe infection right into the delicate inner workings of the skull. Just don't do it.
Well, we've covered the foundations, the safety protocols, and those absolutely critical red flags. You've got the roadmap down, and you understand the anatomy. The only question left is, when your patient's world starts spinning or their hearing suddenly fades, are you ready to step up, be their anchor, and completely ace exam 2? I know you are. Good luck out there, and keep studying smart.